So we've got only 10 minutes to review every single cause of anemia. No worries, I've got you covered. Now, please don't interpret this as medical advice. This is just meant as a review. If you are not a physician, please check your physician. If you are a physician, please check the latest protocols before making any decision. So okay, you've got anemia, you have decreased red blood cell mass in your body. First question, how large are your red blood cells? How many femtoliters do they have? If they have less than 80 femtoliters, you have a microcytic anemia. If they have between 80 and 100 femtoliters, you have a normocytic anemia. If your mean corpuscular volume is greater than 100 femtoliters, then you have macrocytic anemia. So if you have microcytic anemia, second question, how is your serum iron? If it's high or normal, you have either sideroblastic anemia or thalassemia. So your serum iron is normal. Third question, do you have ringed sideroblasts? If you do, you have sideroblastic anemia. Are you an alcoholic? If you are, you probably have sideroblastic anemia. Have you been poisoned by lead? If you have, you probably have sideroblastic anemia. Is the anemia solved with B6 pyridoxine administration? If so, you have sideroblastic anemia. However, if your serum iron is normal and the anemia is present from an early age, then you have thalassemia. Was the anemia present at birth? If so, congratulations, you have alpha thalassemia. If not, you could have either alpha or beta thalassemia. Check your genes. If they are deleted, it's probably alpha thalassemia. If they are mutated, it's almost certainly beta thalassemia. However, if you have microcytic anemia and your serum iron was decreased, next question is how is your ferritin? If it's high, you have anemia of chronic disease. If it's low, congratulations, you have iron deficiency anemia. However, if your red blood cells have a volume greater than 100 femtoliters, then you have macrocytic anemia. So if you have macrocytic anemia, the first question to ask is how many lobes do your neutrophils have? Because if they have between 3 and 5 lobes, then you have normal neutrophils, and your anemia is probably caused by liver disease, alcoholism, or taking 5-fluorouracil or other drugs. However, if your neutrophils have more than 5 segments, then you have neutrophil hypersegmentation, which means you have megaloblastic anemia. So if you have macrocytic megaloblastic anemia, the next question is, do you have neurological symptoms? If you do, you have vitamin B12 deficiency. If you don't, the next question is, how is your methylmalonic acid? If it's normal, you have folate deficiency. If it's high, you have B12 deficiency. Finally, if your red blood cells are of normal size between 80 and 100 femtoliters, then you have normocytic anemia. So if you have normocytic anemia, the first question is, are you bleeding profusely? If the answer is yes, stop watching this video and call a local emergency service, because you've got hemorrhage. If you don't have hemorrhage, then the next question is, do you have jaundice, elevated unconjugated bilirubin, and or bilirubin gallstones? If the answer is yes, you have a destruction or loss problem or hemolysis. If you don't have these symptoms, the next question is, how are your reticulocytes? If they are lower than 3%, then you have a underproduction problem. If they are higher than 3%, then you have a destruction loss problem or hemolysis. If you have an underproduction problem, the next question is, how's your EPO, your serum erythropoietin levels? If they are low, you have anemia of renal failure. If your EPO is normal or high, then the next question is, did you already have a congenital anemia that has worsened recently? If the answer is yes, then you probably have anemia because of parvovirus B19 infection. If the answer is no, then you probably have aplastic anemia, myelophytosis, or myelofibrosis. And make sure to also check your other cell lineages because you probably have pancytopenia, not just anemia. On the other hand, if you have more than 3% of reticulocytes and your problem is actual hemolysis, then the next question is, do you have splenomegaly? If you have splenomegaly, then you have extravascular hemolysis. If you don't have splenomegaly, the next question is, do you have hemoglobinemia, hemoglobinuria, and hemosideruria? If the answer is yes, then you have intravascular hemolysis. If the answer is no, then the third and final question is, how is your heptoglobin? If your heptoglobin is normal and increased, then you have extravascular hemolysis. If your heptoglobin is depleted, then you have intravascular hemolysis. If you have extravascular hemolysis, the next question is, do you have hemoglobin S? If you have hemoglobin S, congratulations, you have sickle cell anemia. If you don't have hemoglobin S, do you have hemoglobin C crystals? If you have hemoglobin C crystal, then you have hemoglobin C disease. If you don't have either hemoglobin S or hemoglobin C crystals, the next question is, do you have spectrin and chiron or band 3.1 defects? If the answer is yes, then you have hereditary spherocytosis or hereditary elliptocytosis. If you don't know about these effects but you have spherocytes, then the next question is, do you have either positive COMPS test or systemic lupus erythematosus, chronic lymphocytic leukemia, or are taking specific drugs? If the answer is yes, then you most likely have IgG-mediated hemolytic anemia. Meanwhile, if you have intravascular hemolysis, then the next question is also, do you have a positive COMPS test Or do you have a recent history of mycoplasma pneumonia infection or infectious mononucleosis? If the answer is yes, then you probably have IgM-mediated hemolytic anemia. If the answer is no, the next question is, do you have Heinz bodies and bite cells on peripheral blood smear, or was your crisis precipitated by sulfa use or consumption of fava beans? If the answer is yes, then you probably have G6PD deficiency. If the answer is no, the next question is, do you have a positive sucrose test or complement activation and morning hemoglobinuria? If the answer is yes, then you surely have paroxysmal nocturnal hemoglobinuria. If the answer is no, then the next and final question is, do you have schistocytes? If the answer is yes, then you have angiopatic hemolytic anemia. The next question is, do you have prosthetic valves or aortic stenosis? If you do, then they are the cause of angiopatic hemolytic anemia. If you don't have, then you have microangiopatic hemolytic anemia. And the next question is, do you have NMTS13 deficiency or neurologic and renal symptoms? If you do, then you probably have TTP, thrombotic thrombocytopenic purpura. If you don't, then the next question is, are you septic? If the answer is yes, then you probably have disseminated intravascular coagulation or DIC. If you don't, the next question is, are you pregnant? If you are pregnant, you might either have HELLP syndrome, hemolysis, elevation of liver enzymes and low platelets, or you may also have GIC. If you're not pregnant, the last question is, are you a child? If you are a child and are currently infected by E. coli, then you may have hemolytic uremic syndrome. So, there you have it, a complete review of anemia in less than 10 minutes. I guess I don't need to say that some of the pathology was simplified for brevity, so maybe don't take everything ipsis literis, and do consider that the investigation algorithm may vary based on your patient and where you are, and rare and uncommon presentations are possible. Thank you for spending your time with me, and you're welcome for not wasting your time. If you liked this video, maybe check some of the other ones I've made, and I hope to see you on the next video. Good luck on your studies!